Okay, let's jump right in. If you're a postgraduate optometry student, especially those of you practicing in South Africa, this explainer is built specifically for you. We're going to break down the somatic and autonomic nervous systems, but strictly through the lens of clinical ocular pharmacotherapy. Basically, we're looking at exactly how the body's hardwiring dictates the drops you prescribe every single day in your clinic.
But right off the bat, we absolutely have to credit Dr. Dirk J. Buisen. He's the primary content expert here, and his extensive work is really the foundational bedrock of this guide. His deep insights into diagnostics and pharmacology are what make this entire breakdown possible.
So, we're taking a funnel approach today. We'll start big with the nervous system hierarchy, look at somatic control, dive into the autonomic balancing act, map out key ocular receptors, and finally drill right down into ocular pharmacotherapy in action. Let's kick things off with part 1, the nervous system hierarchy. We really need to start at the very top of the blueprint. At the highest level, there's a very clear separation of duties. The central nervous system, that's your brain and spinal cord, acts as the main command hub. Then you have the peripheral nervous system, acting as the communication lines, hooking that hub up to the rest of the body. From there, it splits. You've got sensory inputs traveling up and motor outputs traveling down. And for us in optometry, we are intensely focused on that motor division, how the brain actually tells the eye what to do. That takes us right into part 2, somatic control in the eye. As we travel down that motor division, the first thing we hit are our voluntary controls. The key distinction here is conscious versus unconscious control. Think of the somatic system as your manual steering wheel. It's in charge of your voluntary, striated muscles. On the flip side, the autonomic system is your body's autopilot. It manages involuntary, smooth muscles and visceral organs without you having to spare a single thought. Now, you actually see the somatic control in action all the time. Every time a patient voluntarily blinks or squeezes their eyes shut during an exam, they are consciously using cranial nerve 7 to fire the orbicularis oculi. When they open their eyes wide, that's cranial nerve 3 engaging the levator muscle. And when you're doing a motility test and they're tracking your finger, they are actively using their somatic system via cranial nerves 3, 4, and 6 to manually steer those extraocular muscles. All right, part 3, the autonomic balancing act. Having covered those voluntary muscles, let's switch gears and look at the autopilot. This is where we see the incredibly beautiful balancing act of the autonomic system. It's basically two divisions constantly pulling against each other. You've got the sympathetic division, your fight or flight response. It dilates the pupils so you can let in more light, to spot that proverbial tiger in the bushes. But pulling the exact opposite way is the parasympathetic division, your rest and digest response, which constricts the pupil. It's just a constant physiological tug of war. To make this whole tug of war actually work, the signals have to cross synapses using highly specific biochemical keys. Acetylcholine is the primary neurotransmitter key for the parasympathetic side, while noradrenaline is the main key for the postganglionic sympathetic side. Remembering these two specific neurotransmitters is absolutely fundamental for everything else we're going to talk about. Which leads us perfectly into part 4, navigating key ocular receptors. Let's see what happens when those biochemical keys find their matching locks. Understanding these specific receptor locations is absolute gold for your postgraduate studies. The sympathetic system deploys alpha-1 receptors, acting as locks, on the iris stylator muscle to trigger mydriasis. Meanwhile, the parasympathetic system uses muscarinic M3 receptors locked onto the iris sphincter to cause meiosis. And down in the ciliary processes, sympathetic beta-2 and alpha-2 receptors play a massive role in regulating aqueous production, while parasympathetic M3 receptors in the ciliary muscle control accommodation and actually help open up trabecular outflow. You've literally got to know where these locks live to predict what your drops will do. And that brings us to our final section, ocular pharmacotherapy in action. This is the bottom of the funnel, where we translate the neuroanatomy into your actual practice. We can categorize practically our entire ophthalmic drug arsenal based on two very simple actions. Drugs can either mimic a system, which we call mimetics or agonists, or they can block a system, which we call lytics or antagonists. So because we have two autonomic systems and we can either hit the gas or hit the brakes on them, we end up with 4 primary pharmacological categories. Sympathomimetics hit the gas on fight or flight. Sympatholytics hit the brakes on it. Parasympathomimetics stimulate rest and digest. Parasympatholytics block it. And here is a massive clinical secret. Because these two divisions constantly oppose each other, blocking one system often yields a clinical effect that looks just like stimulating the other. For example, blocking the sympathetic system with a beta blocker allows the underlying parasympathetic tone to just completely take over. Let's look at some real-world specifics.
When you administer a drop like phenylephrine, you are directly acting as a sympathomimetic. It hunts down those alpha-1 receptors on the iris dilator and forces them to contract, giving you that rapid mydriasis. It also hits alpha receptors on conjunctival vessels to blanch them out. But you've got to remember what else the sympathetic system controls. A careless drop of 10% phenylephrine in an elderly or diabetic patient can trigger a really dangerous systemic cardiovascular spike. Conversely, let's talk about pilocarpine. This drug acts as a parasympathomimetic. It brings that rest and digest neurotransmitter keys straight to the muscarinic M3 receptors. This stimulates the iris sphincter to cause miosis, but crucially, it also stimulates the longitudinal ciliary muscle. When that muscle contracts, it literally tugs on the scleral spur, widening up those trabecular spaces and drastically increasing aqueous outflow. It's a mechanical opening that drops intraocular pressure fast. And when you need to block these systems, you reach for anticholinergics. Tropicamide, for instance, is a parasympatholytic. It blocks the resting parasympathetic state. And without that constant tug from the sphincter, the pupil just naturally dilates out, giving you cycloplegia. On the flip side, beta blockers are sympatholytics. By blocking the sympathetic beta receptors in the ciliary processes, they completely break the drive for aqueous production. You're effectively turning off the internal faucet for your glaucoma patients.
As you head back into the clinic today, I want to leave you with a really provocative question to chew on. Based on the precise receptor mechanics we just mapped out, if a patient presents in your chair with an acute angle closure glaucoma emergency, why is an alpha-1 agonist like phenylephrine strictly contraindicated, downright dangerous even, while a parasympathomimetic like pilocarpine becomes your absolute go-to? Think about the physical mechanics of those microscopic muscles pulling against each other. Because truly understanding that why is the real art of clinical pharmacotherapy.